One more minute. Maybe 30 seconds. It's an important process. Well, people will find it interesting. It's important. Colleen, you're actually seeing me here because I'm not seeing anything on here tonight. Are we good? Okay. Okay, great. Good afternoon, everybody. Although less bodies than last week, but hopefully they'll still come in. It's my pleasure today to welcome you to Grand Rounds and to introduce our speaker, Dr. Monika Kumaraswamy. She's an associate professor of medicine in the Division of Infectious Diseases and Global Public Health, and associate director of the Clinical Microbiology Lab at the VA San Diego. She earned her MD from the Medical College of Wisconsin and completed her internal medicine residency in the International Health Track at Case Western Reserve University. She came to UCSD for her infectious diseases clinical and postdoctoral research fellowships, and then we were lucky to have her join the faculty. Dr. Kumaraswamy's primary research interests include modernizing antimicrobial susceptibility testing, developing new diagnostic testing modalities, and identifying novel therapeutic strategies to combat multi-drug resistant bacterial infections by understanding the interactions of innate host defense with conventional antibiotics and mechanisms of antibiotic resistance. She has authored nearly 20 peer-reviewed publications on these topics. She's the co-PI on an NIH R01 on the surprising efficacy of discounted antibiotics versus MDR gram-negative pathogens occurring through innate immune sensitization, and PI on a UCSD Health Sciences research grant on boosting beta-lactam activity against Mycobacterium abscessus complex. She'll be speaking today on a very, very important topic, which is advancing antimicrobial susceptibility testing, investigating antibiotic-host defense interactions.
Thank you for that very kind introduction and for the warm welcome. To start, just on a personal note, I've always been enthusiastic about infectious diseases, but never imagined becoming a clinical microbiologist. It wasn't until coming to UCSD over 10 years ago, I'm dating myself here, that I gained exposure to the clinical microbiology lab. And here at UCSD and the VA, we have a rich tradition of the clinical microbiology lab being directed by ID-trained physicians. It wasn't until I had this experience that I had this aha moment and found something that I was extremely passionate about. And I think it's really important that we have these sorts of experiences and training. And we also seek these additional experiences. I think it not only helps us be better clinicians, provide better care to our patients, but also could lead to these aha moments where we discover something we're incredibly passionate about. And for me, that was clinical microbiology. Today, I'm going to be talking about advancing phenotypic approaches to antimicrobial susceptibility testing. Before I begin, I just want to mention that I have no actual or potential conflicts of interest in relation to this particular research program or presentation. The work to be presented today is funded by an active NIH R01 grant and has previously been funded by a NIH KL2 Career Development Award and a prior NIH U01 Systems Biology grant. Here you can see an unfortunate 4-year-old girl who developed progressively worsening cellulitis involving her left cheek. She went on to experience dysphagia, had poor oral secretions resulting in respiratory distress. Desperate to save her life, doctors at the time decided to administer an experimental therapeutic known as penicillin. Now, penicillin had been discovered 14 years earlier, but had not gone into widespread implementation or use. Shortly following administration of the drug, the girl rapidly improved. By day 4, she was up in bed and smiling, and by day 9, she was back to her old self. Now, you can imagine had this infection occurred 10 years earlier, that is prior to the widespread use of penicillin, that this young girl would likely not have survived. Now, penicillin was discovered in 1928 by Sir Alexander Fleming, but it was extremely difficult to isolate and purify. It took over a decade, including collaborations with researchers at the University of Oxford and our US Department of Agriculture to actually be able to develop the capacity to manufacture and commercialize penicillin on a large scale. And we see its use and implementation start at the onset of World War II. And with that, we have this ushering of a golden age of antibiotic discovery, where we have numerous new classes identified in subsequent decades. Unfortunately, what we also see during this time period is the emergence of an arms race. With the introduction of each new antimicrobial class into clinical practice, we also see the rapid emergence of resistance. And as the decades have gone by, the drug discovery pipeline for new antimicrobial classes has dwindled. And as a result, we're potentially at risk for succumbing to infections that were once treatable. A recent report released by the World Health Organization notes that antimicrobial resistant infections are responsible for well over 700,000 deaths worldwide and regards it to be a top 10 threat to human life. Here in the United States, antibiotic-resistant infections number around 3 million, resulting in about 50,000 deaths and causing over $30 billion in healthcare expenditures annually. In fact, it's estimated that by the year 2050, in the absence of any interventions, that antibiotic resistance will contribute to over 10 million deaths. This will be more deaths than from diabetes and cancer combined. So how exactly do we identify antibiotic resistance? In the diagnostic laboratory, minimum inhibitory concentration testing, or the MIC assay, plays a critical role in helping to define bacterial and antibacterial resistance. It also has tremendous implications in guiding therapeutic selections for management of bacterial infection. Minimum inhibitory concentration, as the name implies, is the minimum concentration of an antibiotic required to inhibit the growth of a microorganism. In the clinical microbiology laboratory, we have various diagnostic modalities available to us to conduct antimicrobial susceptibility testing and to identify the MIC. These include the E-test or epsilometer test, broth microdilution, which is widely considered the gold standard for identifying the MIC, and disk diffusion. Data obtained from these methodologies is used to outline and generate a profile giving us the resistance or susceptibility of a microorganism to a panel of antibiotics. And this is based on clinical breakpoints established by organizations such as the FDA, UCAST, or CLSI. And these antibiotic susceptibility profiles that are generated have tremendous clinical implications in helping clinicians select viable therapeutic options for managing infection. Here to your right, you can see an example of a truncated report for a multi-drug resistant isolate of Pseudomonas, where we see a string of Rs and unfortunately no viable therapeutic options. So minimum inhibitory concentration testing is identified via antimicrobial susceptibility testing. Traditional antimicrobial susceptibility testing centers primarily around three components. That is the media, the bacteria, and the antibiotic. It essentially focuses on assessing the activity of an antibiotic against bacteria using a media that is designed to support robust bacterial growth. It is highly standardized as well, depending on the methodology. Apart from using a media, again, that supports robust bacterial growth, such as CA-MHB, we also use bacteria at fixed concentrations. For example, we use about 1.5 times 10 to the 8th colony-forming units per mil, or a McFarland standard of 0.5 for the disk diffusion methodology, or 5 times 10 to the 5th CFU per mil in broth microdilution, a very dramatic difference in concentration. And lastly, we assess the antibiotic, and we usually use either a standardized or serial concentrations, depending on the methodology, and primarily assess a single agent. Essentially, with traditional antimicrobial susceptibility testing, we're evaluating solely the bacteria and the antibiotic. Now, this approach was developed over 60 years ago and has remained largely unchanged. That being said, it served us extremely well in helping us identify therapeutic options for managing challenging bacterial infections. Now, a major crux of traditional antimicrobial susceptibility testing is the use of cation-adjusted Mueller-Hinton broth, or CAMHB. Now, CAMHB was originally developed in 1941 by two investigators at Harvard, Drs. Mueller and Hinton. And they originally developed this media to sustain the growth of Neisseria. Cation-adjusted Mueller-Hinton broth is comprised of beef extract, casein hydrolysate, and starch. It also maintains a neutral pH at 25 degrees Celsius and is often supplemented with the cations magnesium and calcium. And this is done to better support the growth of Pseudomonas and also to help uncover antimicrobial activities of certain antibiotics, such as daptomycin and napsilin. Now, this media is used in traditional antimicrobial susceptibility testing because it's able to support robust bacterial growth. That being said, it isn't necessarily reflective of the host human environment. It has served us well in traditional antimicrobial susceptibility testing, but has the potential to yield pseudo-resistance, which I'll get into later in this presentation, and also pseudo-susceptibility. This is where we identify the activity of an antimicrobial agent against bacteria in vitro that doesn't necessarily translate to in vivo efficacy. In the clinical microbiology lab, we suppress this data to prevent clinicians from acting upon it. Some examples of this include meropenem versus Stenotrophomonas multifilia, ampicillin versus beta-lactamase producing Klebsiella pneumoniae, ceftriaxone versus AMP-C harboring Klebsiella aerogenes, and trimethoprim sulfamethoxazole versus Enterococcus species. So this media has tremendous utility, but obviously still has some limitations. It's also important to note that it's completely devoid of host environmental factors. We must remember that even before the first patient encounter and administration of antibiotic therapy, that a patient's infection is already being combated by components of their host innate immunity. This includes their serum complement, phagocytic cells such as neutrophils or macrophages, platelets and red blood cells, which are increasingly being appreciated to have antimicrobial properties, and endogenous antimicrobial peptides, such as IL-37, human beta defensin, and human neutrophils, which are present within phagocytic cells or keratinocytes. Now, this is completely unaccounted for in the traditional antimicrobial susceptibility testing paradigm. That is the dynamic interactions involving the bacteria, the antimicrobial agent, and components of host innate immunity. And as a result, we may potentially be overlooking antibiotics that have the potential to work in concert with our innate immune system against multi-drug resistant organisms. So what if we were to take a more contemporary approach to antimicrobial susceptibility testing, incorporating host environmental factors? What exactly could that look like? Well, we could use a media more reflective of the mammalian environment, such as RPMI 1640 or Dolbeckio's modified eagle media. These media possess a bicarbonate buffer system, a crucial physiologic buffer present within the human host. They're also able to support not only eukaryotic cells, but bacteria as well. We could, of course, include host defense factors, neutrophils, macrophages, serum complement, and endogenous antimicrobial peptides. We could better consider the kind of infection we're trying to treat. Is it a high burden infection or a low burden infection? Should we be assessing activity using a high inocula of bacteria or a low inocula of bacteria? Is the organism intracellular or extracellular, aerobic or anaerobic? What kind of infection exactly are we trying to treat? Is it pneumonia, a bacteremia, or urinary tract infection? And lastly, we could incorporate the antibiotic, looking not only at a single agent, but perhaps dual agents, and their potential to sensitize bacteria to clearance by host defense. We could also better consider the properties of the antibiotic themselves. Does it concentrate intracellularly? How well does it penetrate tissue? Is it affected by the pH of the environment? thinking outside the box. Now, there's a growing community of investigators that are increasingly identifying hidden immune synergizing activities of antibiotics currently overlooked by traditional antimicrobial susceptibility testing. And this is against fearsome multi-drug resistant gram-positive and gram-negative organisms. By incorporating host environmental factors, we could have the potential to more accurately identify the susceptibility and resistance of FDA-approved antibiotics against multi-drug resistant organisms. Here, I'm going to present a few different examples where we assessed azithromycin activity in a more physiologic context. Now, azithromycin is a macrolide antibiotic that is never prescribed as monotherapy for serious multi-drug resistant gram-negative infections secondary to Pseudomonas, Klebsiella, or Acinetobacter. And that's because of poor or absent in vitro activity by standard MIC testing. Here we evaluated the MICs of azithromycin for several different clinical strains of multi-drug resistant Pseudomonas aeruginosa, Klebsiella pneumoniae, and Acinetobacter baumannii, using traditional broth microdilution and in accordance with CLSI guidelines. This was performed in the standard bacteriologic medium, cation-adjusted Mueller-Hinton broth, and more important to the task at hand, using the more physiologic mammalian tissue culture medium, RPMI. And what we observed is a dramatic multifold reduction in the MIC of azithromycin in supplemented RPMI. And to us, what this hinted at is the potential for in vivo efficacy. So we decided to explore this further. We performed kinetic killing assays to determine the mean bactericidal concentration of azithromycin against multi-drug resistant Pseudomonas aeruginosa, Klebsiella pneumoniae, and Acinetobacter baumannii, using both the bacteriologic medium, cation-adjusted Mueller-Hinton broth, and the more physiologic RPMI with 5% LB. And what we observed is a striking multifold reduction in the log colony forming units, that is the bacteria, over a 24-hour time period. We observed striking bactericidal activity against all three of these multi-drug resistant gram-negatives in RPMI. And this was in comparison and contrast to CA-MHB. Now, azithromycin is a macrolide antibiotic. It functions to inhibit protein synthesis by binding to the 50S subunit of bacteria. Here we employed both electron microscopy and a novel fluorescence microscopy technique known as bacterial cytological profiling to determine the cellular pathway perturbed by azithromycin and RPMI. And what we found is that we had nucleoid collapse into this low energy toroid shape for Acinetobacter baumannii cells that had been treated with azithromycin in RPMI. And this was observed in both electron microscopy and with bacterial cytological profiling. This toroid nuclei is a hallmark feature of protein synthesis inhibition, and again was observed for these Acinetobacter baumannii cells. We also assessed the intensity of the DNA dye DAPI and saw that we had increased relative intensity for Acinetobacter baumannii cells in RPMI versus CA-MHB. And this is in the absence of azithromycin, suggesting that we have increased cell membrane permeability in tissue culture media. This intensity was further enhanced in the presence of the drug. Azithromycin was also noted to have activity against multi-drug resistant Pseudomonas, Klebsiella, and Acinetobacter that was markedly potentiated in the presence of 20% serum. Now, serum harbors complement, a major host defense factor that helps to form the membrane attack complex against gram-negative bacteria, and also coats bacteria, opsonizes bacteria to facilitate phagocytosis by neutrophils. Azithromycin was also evaluated in combination with LL37. LL37 is a critical endogenous antimicrobial peptide. It's present abundantly in phagocytic cells like neutrophils and macrophages. It can also be found in keratinocytes, and it plays an important role in combating invasive pathogens. Here we assessed azithromycin and LL37 at subtherapeutic concentrations alone, and in combination, we saw potent bactericidal synergy. With bactericytological profiling, we observed increased DNA di-DAPI staining intensity and the formation of toroid nuclei. Again, hallmark features of protein synthesis inhibition for multi-drug resistant Acinetobacter baumannii cells treated with both azithromycin and LL37 compared to either agent alone. Furthermore, we noted increased intracellular uptake of NBD-labeled azithromycin, a fluorescently labeled azithromycin, in the presence of LL37. This is consistent with the known activity of LL37, which is to disrupt cell wall biogenesis and the cytoplasmic membrane of gram-negative bacteria. And with that disruption, we have increased intracellular uptake of azithromycin, and then it's then able to act at the level of the bacterial ribosome. Buoyed by these unexpected findings, we decided to assess the efficacy of azithromycin monotherapy in a murine pneumonia model. Here, mice were intratracheally infected with multi-drug resistant Acinetobacter baumannii and treated with either phosphate buffered saline or azithromycin at 50 or 100 milligrams per kilogram subcutaneously. This was done to achieve serum levels consistent with human dosing. And what we observed is a striking multifold reduction in bacterial recovery from the lung homogenate of mice that had been treated with azithro. In bronchoalveolar lavage fluid, azithromycin-treated mice were also noted to have 50% fewer neutrophils. Reduced pro-inflammatory cytokines, including IL-1 beta, IL-6, MIP2, and reduced infiltration of bacteria and neutrophils on histology. Lastly, we conducted a murine model of survival using a lethal inocula Acinetobacter baumannii, and we observed that azithromycin-treated mice had dramatically improved survival compared to the PBS negative control. Azithromycin-treated mice on day 5 had about 89% survival versus only 22% for those that received PBS. So in sum, azithromycin was uncovered to have potent synergistic activity in combination with components of innate immunity like the endogenous antimicrobial peptide LL37 with a serum complement, and this all translated into surprising in vivo efficacy using these murine models of infection. We next evaluated azithromycin activity against multi-drug resistant Stenotrophomonas multifilia. Stenotrophomonas multifilia is an opportunistic pathogen. Clinically speaking, we often see it as a colonizer in patients who are profoundly immunosuppressed and hospitalized for prolonged periods of time. That being said, when it is a true cause of infection, it's associated with significant morbidity and mortality, most commonly causing either bacteremia or pneumonia. It's also intrinsically resistant to multiple antibiotic classes. Here we assess the MIC of azithromycin using a panel of multi-drug resistant Stenotrophomonas multifilia isolates in both the standard bacteriologic medium, CA-MHB, and the more physiologic mammalian tissue culture media, RPMI, supplemented with 10% LB. And what we observed again is this striking multifold reduction in the MIC of azithromycin and RPMI. We next proceeded to evaluate azithromycin activity, the cationic peptide activity of colistin, and the endogenous cationic peptide LL37 in both CA-MHB and RPMI. Azithromycin and LL37 were observed to have potent bactericidal activity, and colistin had bacteriostatic activity in mammalian tissue culture media. Azithromycin and colistin and azithromycin and LL37 were also evaluated in combination. And at a quarter MIC, we see potent bactericidal synergy only in RPMI. The novel fluorescence microscopy technique, bactericytological profiling, was again employed here. And in the presence of both colistin and IL-37, we see increased intracellular uptake of this NBD-labeled or fluorescently labeled azithromycin into these steno cells. And this is consistent with the known activity of IL-37 and colistin, which is to perturb the bacterial membrane and form pores, thereby facilitating intracellular uptake of the drug and allowing it to act at the level of the bacterial ribosome. Azithromycin was also noted to sensitize multi-drug resistant Stenotrophomonas multifilia to neutrophil killing. It also reduced the bacterial recovery from lung homogenate of AJ mice that were intratracheally infected with either a high inocula or a low inocula of steno during a 24-hour and 48-hour time period. Histopathology also revealed reduced pulmonary infiltration and inflammation among mice that had been treated with azithromycin. So, here we observed azithromycin activity against various multi-drug resistant gram-negative rods. This activity was overlooked by standard susceptibility testing, and we probed it further with other CF pathogens, including Achromobacter xylosoxidans. Now, Achromobacter xylosoxidans is an emerging nosocomial pathogen. It has been implicated with a variety of different infections, including pneumonia, and is increasingly being isolated from the respiratory tract of patients with CF. In CF patients, its presence has been implicated with more severe lung disease, pulmonary exacerbations, and pulmonary inflammation. Here we assess the activity of azithromycin against multi-drug resistant strains of Achromobacter xylosoxidans derived from CF patients. And we did this again in the standard bacteriologic medium, cation-adjusted Mueller-Hinton broth, and using the more physiologic RPMI supplemented with 10% LB. And again, we have this striking activity against these Achromobacter isolates and RPMI. Now, the growth of Achromobacter xylosoxidans was evaluated in both CA-MHB and supplemented RPMI at 0, 4, 8, and 24 hours, and noted to be roughly equivalent in both media. However, with the addition of azithromycin, 0.25 milligrams per liter, we observe only bactericidal activity in RPMI and see that this activity is absent in CA-MHB. Additionally, bactericytological profiling revealed increased intracellular uptake of this fluorescently tagged azithromycin among Achromobacter cells, but again, only in RPMI. Now, Achromobacter xylosoxidans has a propensity to form thick biofilm. Here we assessed various concentrations of azithromycin against Achromobacter xylosoxidans biofilm biomass using optical density. And what we observed is that at 4 milligrams per liter of azithromycin is about a 75% reduction in biofilm in the setting of RPMI versus only 25% in CA-MHB. This is in comparison and contrast to untreated control. Azithromycin pre-treatment and exposure at a quarter MIC, 1/2 the MIC, and 1 times the MIC identified in RPMI was also noted to dramatically sensitize the bacteria to clearance by whole blood, serum complement, and neutrophil killing. And I just want to emphasize that at a quarter MIC, we have an exquisitely minute concentration of azithromycin, demonstrating its potent ability to sensitize this bacteria to clearance by components of host defense. Here is yet another example evaluating the dynamic interplay between antibiotics and components of host innate immunity involving NDM1 producing Klebsiella pneumoniae and avibactam. Now, avibactam is a non-beta-lactam beta-lactamase inhibitor that does not have or is not known to have any direct activity against NDM1 producing organisms. And what investigators found here is that avibactam dramatically sensitizes NDM1 producing Klebsiella pneumoniae to killing by this endogenous antimicrobial peptide IL-37, which again is found abundantly in phagocytic cells and in keratinocytes. When IL-37 was evaluated in combination with avibactam, potent bactericidal synergy and killing was observed against not only NDM1 producing strains, but also another carbapenemase producing isolate of Klebsiella. Furthermore, no bacterial regrowth was observed at 24 hours, highlighting the potency of this combination. Avibactam was also noted to markedly sensitize carbapenem-resistant NDM1 producing Klebsiella pneumoniae to killing by human serum, neutrophils, and platelets. Lastly, avibactam monotherapy was observed to reduce the bacterial recovery of NDM1 producing Klebsiella pneumoniae in a murine pneumonia model. Here from the Spellberg and Luna labs, rifabutin activity against extreme drug-resistant Acinetobacter baumannii was evaluated using a eukaryotic nutrient-limited screen. And what these investigators found is that in iron-poor media, such as RPMI and iron-depleted Mueller-Hinton broth, that rifabutin actually had hyperactivity against extreme drug-resistant Acinetobacter. And these findings correlated with FHUE gene expression. FHUE encodes for iron-regulated outer membrane protein transporter and is upregulated in iron-poor conditions and downregulated in iron-rich conditions. And so with this upregulation in RPMI and iron-depleted Mueller-Hinton broth, we have increased expression of this protein transporter that essentially functions as a Trojan horse, bringing rifabutin into Acinetobacter. They followed this up with a murine model of infection, specifically aspiration pneumonia model, where they infected mice with a carbapenem-resistant strain of Acinetobacter baumannii. And they treated these mice with either rifabutin, RBT, rifampin, or phosphate buffered saline. And what they found is the rifabutin group had a reduced bacterial recovery from lung homogenate and increased survival compared to the rifampin and PBS groups. We also assessed the dynamic interplay between polymyxins and components of host defense. Now, polymyxins are widely regarded to be an antibiotic class of last resort in therapy of extreme drug-resistant gram-negatives. They were actually discovered in the late 1940s, but didn't go into clinical use until the 1960s. During that time period, they rapidly fell from favor because of associated nephrotoxicity and neurotoxicity. However, in the last 20 years or so, we've seen a resurgence in its use because of the increasing incidence of extreme drug-resistant gram-negatives. Now, polymyxins are a non-ribosomally synthesized cyclic cationic peptide that have a large hydrophobic tail. This large hydrophobic tail serves to disrupt the gram-negative membrane via electrostatic interactions, resulting in cell membrane permeabilization, leakage of intracellular contents, and ultimately cell death. Now, there are about 5 subclasses of polymyxins, which range from A through E. However, clinically speaking, only colistin and polymyxin B are used intravenously to treat extreme drug-resistant gram-negative infections. Now, historically speaking, colistin resistance has primarily been localized to the bacterial chromosome, and as a result, this has impeded its spread across different bacterial populations. Unfortunately, in recent years, we've seen the emergence of a horizontally transferable plasmid-mediated mobilized colistin resistance determinant known as MCR. MCR encodes for phosphatidylethylamine transferase. And what this enzyme does is it facilitates the chemical modification of lipid A, either via the addition of L-aminoarabinose or the attachment of phosphatidylthylamine to the 1,4-D-phosphate group. And what these chemical modifications ultimately result in is a decrease in the net negative charge of lipopolysaccharide, thus making the gram-negative membrane less anionic. So the less negatively charged gram-negative membrane therefore has a reduced affinity for the positively charged colistin peptide antibiotic. And we have these reduced electrostatic interactions occurring between the cationic colistin and the less anionic gram-negative membrane. Now, MCR was first identified about 10 to 15 years ago in Asia and has since spread worldwide to all major inhabitable continents. Now, generally, MCR harboring Enterobacteriaceae are regarded to have reduced susceptibility to colistin and polymyxin B. And this is because of poor or absent activity identified by a traditional MIC testing. Here we performed comparative MIC testing for both these polymyxins using the standard bacteriologic medium, cation-adjusted Mueller-Hinton broth. And again, in this mammalian, more physiologic mammalian tissue culture medium, or PMI. And we did this using a panel of Enterobacteriaceae known to harbor MCR. This included Escherichia coli, Salmonella, and Klebsiella isolates. And what we again observe is that both colistin and polymyxin B have potent activity against these strains in our PMI. We next evaluated the activity of colistin against MCR-positive Escherichia coli, Klebsiella pneumoniae, and Salmonella enterica. And this was done using kinetic killing assays in RPMI and CAMHB. And again, we see this rapid bactericidal killing of all three of these strains within 8 hours. We also assess colistin activity against these MCR-positive bacteria, that is E. coli, Klebsiella, and Salmonella, and found that this activity was actually dependent on the physiologic buffer bicarbonate. Colistin exposure of MCR positive E. coli was also noted to increase membrane permeabilization via an NPN assay. And this is consistent with our findings observed in our kinetic killing assay, where we saw potent bactericidal activity in RPMI. We investigated E. coli MCR1 expression using quantitative PCR. Here, these E. coli cells were grown overnight, either in cation-adjusted Mueller-Hinton broth or supplemented RPMI. With exposure to subtherapeutic colistin, with no antibiotic, or with L-arabinose, which is a known potent inducer of MCR expression. And what we observe for all conditions in RPMI is decreased MCR1 expression. This decreased expression provides us a likely explanation of why we see increased susceptibility to colistin in mammalian tissue culture media. Colistin was also noted to potently and rapidly kill MCR-positive Escherichia coli, Klebsiella pneumoniae, and Salmonella enterica at either 1 or 2 hours in human whole blood, and also in 10% human serum. And this was at 1/4 MIC, 1/2 the MIC, or 1 times the MIC of colistin. And so again, this is with exquisitely minute concentrations of colistin that we're seeing rapid killing of these bacteria in both blood and serum. These findings of increased killing in serum corresponded and correlated to increased C3 complement binding, where we saw increased deposition of C3 along the bacterial surface of MCR positive E. coli, Klebsiella pneumoniae, and Salmonella enterica using flow cytometry, specifically in the presence of colistin. When we assess this activity using heat inactivated serum, essentially where we cook the complement and denature it, we see that this activity is abolished. We also looked at MCR positive E. coli via fluorescence microscopy and saw that in the presence of 10% serum and colistin, that we have increased fluorescence. We extended these findings of serum and colistin synergy back to standard susceptibility testing, where we assessed the activity of colistin using standard bacteriologic media, CA-MHB, with and without 10% serum. We again used this panel of Enterobacteriaceae known to harbor MCR. And for 10 of the 12 strains which we were able to get to grow in serum, we saw that there was a dramatic reduction in the MIC colistin in the presence of 10% serum. We next evaluated colistin activity using CA-MHB with 10% heat inactivated serum and saw that this effect was abolished, suggesting that the presence of functional complement is needed to uncover this activity. Buoyed by these findings, we decided to assess a colistin monotherapy using a murine model of bacteremia. Here, mice were intravascularly infected with MCR positive E. coli and treated with either phosphate buffered saline as our negative control or ceftriaxone or colistin. Now, it's important to note that this isolate was susceptible to ceftriaxone by traditional antimicrobial susceptibility testing. So this served as our positive control. And what we found 24 hours post-infection and following treatment is that we had reduced bacterial recovery from spleen and kidney homogenate of mice that had been treated with both ceftriaxone and colistin in comparison to the negative control, PBS. We also conducted a murine model of survival and observed that survival was dramatically improved among mice on day 10 that had received either colistin or ceftriaxone in comparison to PBS. For colistin-treated mice, survival was at about 69%. For those that received ceftriaxone, it was 61.5%. And those poor, unfortunate mice that received PBS, it was only about 15%. So in sum, we uncovered potent unrecognized activity of colistin against MCR positive Enterobacteriaceae. This was done in mammalian tissue culture media in synergy with components of host defense, including serum complement and whole blood, and all translated to surprising in vivo efficacy using murine models of infection. Now, it's important to note that these studies have primarily been done at the bench and really need to be more rigorously evaluated. That is, this approach of contemporary antimicrobial susceptibility testing really needs to be more rigorously evaluated in the clinical setting via clinical trials. That being said, I think it offers some really important food for thought. You know, the current antimicrobial susceptibility testing paradigm has remained unchanged for over 60 years. And we're in this era of multi-drug resistant and extreme drug resistant infections. These infections are associated with significant morbidity and mortality, and we have limited to no therapeutic options in some cases. And so we really need to push ourselves to innovate. Some potential advantages to this contemporary approach to antimicrobial susceptibility testing is illustrated by the examples shared, include the identification of unrecognized activities of existing antibiotics. That is, FDA-approved antibiotics that we already have within our arsenal. This approach could also help us better assess antibiotics at the very start of the drug discovery pipeline. And it does this by mimicking host environmental factors, incorporating host defense, and helping us better consider the type of infection we're treating, the characteristics of the pathogen, and the properties of the antibiotic. It could also perhaps one day be used in personalized medicine, where we're using the whole blood phagocytes and serum complement from the patient that has the multi-drug resistant infection and identifying the therapy that works best and in concert with their innate immune system to provide them the best therapeutic outcome possible. Other various investigators that have contributed to these projects and others, I want to thank them for their help, insights, and also very proud to be a part of this group of antimicrobial resistance researchers. And I also quickly just want to acknowledge the many trainees that have contributed to projects involving antimicrobial susceptibility testing. It's been very rewarding, a very particularly rewarding aspect of doing this work. Thank you.
Thank you, Monica. Very interesting and looking towards the future. Do we have questions in the room? Because we do have some online. No, we actually don't have online. So we
Okay.
maybe.
Well, I just have a random question. So, forever we've used sera for markers of complement. Is there better assays? I mean, there's so much stuff that is in sera, including, antibodies. Now that we know if you had a previous infection, those antibodies actually might enhance destruction and phagocytosis. So I just didn't know if you had any better ideas.
Yeah, there are some assays if you're specifically looking for whether it's complement or if it's related to antibody compounds that we can use to help block certain components of the complement cascade and also to neutralize antibody if you're specifically looking for which factor is most responsible, but not an easy thing to do.
It's not, and we've played with it in the lab for a while, so that's why I was trying to pick your brain. But the other point along those lines is whether or not you think that vaccination has any role. So should we start vaccinating us for things so that when we do get infected later in our lives that we have some of this already circulating?
Yeah, that's a great question. I know that there are some therapeutics in development looking at vaccination strategies against organisms like Pseudomonas, obviously group A strep as well. And it would be great if somebody could do a study on that, looking at long-term, whether or not that might be beneficial in preventing infection in the future and bolstering our immune system.
Any other questions? Yeah. I have one in the meantime. It seems awfully labor intensive to do this one antibiotic at a time. Are there any things on the horizon for more rapid high throughput screening to do this, or at least for antibiotics with similar mechanisms to group them together and then see if this works?
That is a great question. And the $1 million question is to actually be able to do this in a high throughput scale. I think at the moment, it obviously is not. It is extremely labor intensive, but I think there's some strategies that we could employ in the clinical micro lab to help make it semi-automated. We could actually do this with THP1 cells, macrophage cell line. Cell lines are used with viral culture, but extremely cumbersome, but it could be done. The other thing too is to incorporate serum as a component of the screening, where you have 10% serum standardized, pooled from 3 donors. So that is something that some labs are looking at. I think another thing too is, looking at it in a more physiologic sense. We talked about tissue culture media, but there are also synthetic medias for different tissues and sites within the body. If you're talking about sputum, urine, there's even synthetic media that's been developed for blood.
Yeah, because that would go to organ susceptibility, right? You have a question here? Go ahead.
I think, Monica, you just kind of answered it. I think, what you guys are working on is fantastic. And it's really looking at the blood environment and environments that have more of the, they're more consistent with RPMI with serum, but maybe we need to start looking at other environments too, other parts of the body, other organs, and creating media specific for those to look at the antibiotic effects in those situations. there's anybody doing that already, but sounds like maybe.
Yeah, I don't, I know that most people have really focused on mammalian tissue culture media. I think another interesting aspect of this work too is, when looking at therapeutic strategies, there have been some papers published, that have showed that bicarbonate helps to resensitize these pathogens to antibiotics. And so, we do this in the ICU, we give patients bicarbonate. Could that be a potential approach to treating drug-resistant infections? Also, if you're looking at an isolated system like the urinary tract, we know that pH can dramatically have an effect on antibiotic activity. And the urologists are very comfortable with this, giving ascorbic acid or sodium hydroxide to alter the pH of a closed environment to restore or enhance antibiotic activity. So I think there are a lot of different things to kind of be gained from studying this approach.
Anything else? If not, thank you for a great talk on a very, very, very important topic and something I'm sure we're going to hear more of in the future. So thanks for telling your story. Oh, great. I'm sorry, I've stopped it and now we have some questions. Can we do the questions? Because they just came up. Okay. Okay, this is from Steph Strathdy. I wanted to commend Monika as a combo of rifampin, colistin, and azithro kept my husband Tom alive when he was battling a pan-resistant Acinetobacter baumannii infection awaiting phage therapy, a true bench to bedside feat. So kudos for that. And she also wanted to ask if you're interested in studying phage antibiotic synergy, which is obviously a timely question.
Thanks, Stephanie, for that. Yeah, it would be wonderful to study phage antibiotic synergy. And I know that's something that we're interested in doing in our lab and also Victor Nizea's as well.
Okay, now we're really going to end grand round. So thank you very much.
Thank you.
Get another clap.